partner relationship, of things like, sorry, I had to push OK for my recording in progress. So even when parents say they're starting to respond to cues already. So some parents will be like, I'm not changing dirty diapers, no way. Or they'll be like, I can't deal with puke. Like, you're going to have to deal with all the puke. And so they're already starting to prepare for that and responding to cues. And so that's that development that occurs early on, prenatally, and then throughout the child's development as well. Parent-child interactions, so patterns of everyday exchange. This is just what it says, right? How they're going to exchange with them. And if you think about it, and if you've ever listened to a mother that's preparing for their baby and you ask them what they're thinking about or what they hope will happen, they'll talk about it. Or if I helped a friend one time after her baby shower, we went and put her changing table together, and she's like, this is where I'll change the baby, and I'll put the diapers here because this is where, it'll be nice and easy to get to them, and I'll sing to them while they're laying there and I'm changing their diaper. And I'm thinking, yeah, it's not always that easy, but that's a great thoughts, right? So she's already starting to plan those patterns of everyday interactions. And that's fantastic, right? That development early on is exactly what parents need to start that attachment, so that when the baby comes, they're able to build that relationship and build the bond, right? So they're moving from attachment to bond early on. One of the things that can be a barrier to this, and there are many things that can be a barrier. We've talked a lot about, adverse experiences, environmental influences, but one of the things that can definitely be a barrier is depression. And so we want to make sure that we acknowledge maternal depression. And that's one of the most under-screened assessments there is, next to prenatal psychosis. And so those two things are not really screened for a whole lot. It's really important to screen for that. We were actually, I was working with a couple people over at the hospital that were talking about how we can get out there and screen more mothers that come across, right? They do it in the NICU and they do it in the MIC naturally because that's what they do every day. But when you don't do that every day, you don't think about screening for that. So we were talking about in the PICU screening for depression, because that wasn't something they were doing at that time. And since then they have started, but when we were talking about it, they're like, I can't believe we don't do that. Like, how many mothers we work with. And even here, when I came in, we talked about it, they're like, yeah, we kind of miss that population. And so many places do. I worked with a woman in a small community setting, and this was her specialty, was maternal depression and psychosis. And she was an amazing advocate because, and I can't even remember the numbers she told me of people who were not screening. And it was just astonishing. So it's really important to screen and to be aware of maternal depression. So predictors of maternal depression, naturally, genetics and biology, a history of depression. So a lot of moms that come to see me have a history of depression, and so we'll screen then, and then we'll keep a close eye on them. I have some moms that are really on top of it. I have some moms that don't think about it, right? And so the ones who have a history of depression worry about it, and so they'll come in and they'll want to make sure that they're keeping an eye on it. Other predictors are naturally those stressors, right? So violence, any type of traumatic event, substance use disorder, other mental health issues within the family, and so those stressors are pretty big. And poor environmental factors. So this can be a predictor, their lifestyle, their environment that they're living in, but also support systems, right? So the mothers that I work with postpartum depression, the ones that are most successful with their depression are the ones that have a good support system. And I think about a lot of the patients I work with and how many don't really have a real good support system. And it worries me because I know that the most success that they'll have is with that support system. And so when they don't have one, I do get worried for them. Maternal depression and anxiety really affects everybody. So we put anxiety in there because a lot of the times during pregnancy, I get a lot of moms that have high anxiety too. And we know that anxiety, depression kind of like run hand in hand. And so we want to make sure that we're screening and making sure of that, because it can come across. Depression can sneak in there when moms have high anxiety, and so they kind of, and like we said, a lot of those symptoms overlap, and so a lot of the times moms will think, well, it's just my anxiety, but sometimes it can be some of that perinatal depression that's sneaking in there. So we want to make sure that we keep an eye on it, but it does affect everybody, right? So not only does it affect the expecting mother, but it also affects their partner, and the baby, of course. So the baby is developing in whatever brew that mom is brewing in that belly. And if it's toxic brew, then it's going to have an impact on the infant and their development, as well as once the baby is born. And so it definitely influences them once the baby is born as well. And as far as partners, it definitely impacts them. I have partners that worry a lot when we have any perinatal depression. The partners are really worried, but even afterwards with the postpartum depression, partners are not only worried, but they also have to pick up a lot of the responsibilities. And so it definitely influences everybody. So we talk about how it does occur preconception. So a lot of the times it can happen beforehand, you know, the history of depression and anxiety, pregnancy, and then up to 2 years postpartum. A lot of the times, you know, I'll have moms that are like, I'm still struggling with postpartum depression. Moms who have never had a history of depression. I have one in particular that their baby was about 1.5 years, and she's like, I'm still struggling with my postpartum depression. And she was like, this is not normal. I'm going into some other nervous breakdown. And I was like, you're not. It can happen up to 2 years. It's okay. But I can't remember where she read it somewhere that it was only 1 year. And so I was like, it's okay. So she understood, and quite honestly, it was like a month later, she really started to feel much better, and she started titrating off her medication and did it successfully at that point. So she did really well. Doesn't always happen that smooth, but love those good cases, right? Maternal depression. So we look at it in different areas. We look at it as prenatal depression, postpartum blues, postpartum depression, and then postpartum psychosis. There's also prenatal psychosis, which is really, it's like really rare, but I did have a mom with prenatal psychosis, and she ended up being hospitalized. She had a lot of suicidal ideations and visions of really harming herself and her family, and just needed to hospitalize. So, but it took a while for her to come out with that, talk about that, and identify it. And then she was really embarrassed by it, which is what a lot of moms struggle with. I mean, we know a lot of moms that experience the baby blues, right? So the postpartum blues. But finding that line of where it crosses into postpartum depression, we'll talk a little bit about, and even into psychosis. So we'll go over some of that symptomology so that you know how to differentiate those. So prenatal depression is excessive low moods, tearfulness, irritability, and insomnia. And so anybody know anybody pregnant right now? You?
I do, yes.
So what do these symptoms seem like?
Right now she feels like she has a lot of different cravings. She feels a little puffy and kind of not her usual like physical self, which I think kind of gets to her.
Yeah. So you're right. Like there's a lot of things that pregnant women experience that they don't quite feel like themselves, right? And if you've never had a history of any type of mental health, it's kind of hard to identify these pieces, right? Like the tearfulness, yeah, you can identify that. But again, a lot of pregnant women become tearful. Their hormones are raging and they become tearful. Irritability can be increasing, and insomnia. But again, these are sometimes signs. And this is why it's so under-screened, because a lot of the times this is just played off like it's because you're pregnant. It's because of your hormones, right? This is what you're supposed to be experiencing. Low moods. Oh, it's just because you're tired, right? You're pregnant, so you're tired. And so a lot of these things are played off, and especially a lot of moms gain higher anxiety and depression towards the end of their pregnancy, and a lot of it is played off, especially then, because that's when they're gaining most of their weight. That's when the baby is developing the most, and they're ready to nest, right? They're getting ready and in preparation, and people are like, oh, you're just nervous about the baby coming. But the reality is that sometimes they're experiencing some depression. So screening is really important. Postpartum blues. So high percentage, right? 50 to 80% of all women experience postpartum blues within the first 10 days after childbirth. So this is because the hormones are rearranging, right? You're going from one extreme to the next, and your body's trying to regulate back. And a lot of the times that can shift your moods. And so some of the same symptomology, excessive low moods, tearfulness, irritability, insomnia, it'll peak at 5 days or hit its high time, but should end after 2 weeks. So after 2 weeks, postpartum blues should be ending. So 2 weeks post delivery, and then you're moving into more postpartum depression. And so this is more of the prolonged depression. And we start to see some different signs and symptoms. So we see more appetite disturbance, low mood, irritability, sleep the same as postpartum blues or prenatal depression. But postpartum depression, we start to see some appetite disturbance, fatigue, loss of interest. That's probably my biggest indicator. A lot of moms will talk about loss of interest or inability to be happy about anything. And then I have many moms that finally admit to the self-harm of themselves and babies. Now, the postpartum psychosis, you're looking at hallucinations with paranoia around suicide and harming their babies, so killing their babies. A lot of moms, well, and I don't have a lot to compare, but from the literature I read in psychosis, it's more of killing their babies versus self-harm, right? And so self-harm, they'll talk about, harming themselves and sometimes harming their kids. But with psychosis, what they're doing is they're envisioning it and they're seeing it happen, right? And they're having hallucinations that are telling them to do it. And that's the difference. That's what you'll see in the difference with that. Okay, so I'm going to play this video for you guys, and then I'm going to stop sharing for a minute and just kind of solicit some of your responses from this and what your thoughts are. Can you all hear this?
Yes, we can.
Well, my guess is everyone here is either a mom, has a mom, or knows a mom. Well, this story is for all of us. In June of 2018, my husband and I welcomed a third child, another boy, to join his two older brothers, ages 7 and 4. We were all so in love with him. I couldn't wait to spend the summer bonding and enjoying the beautiful outdoors with my family of 5. But instead, I spent most of my summer in a dark bedroom, suffering from a severe and debilitating case of postpartum depression, also known as PPD. By mid-July, on one of the worst nights when I couldn't sleep, my bedroom fan began to chant to me, "Singe their clothes, singe their clothes," beckoning me to light my house on fire and burn my children. I had 3 kids to raise and a nonprofit organization to run, and yet here I was hearing voices in my head telling me to hurt my family. I'm here today to tell my PPD story because my hope is it will help destigmatize and normalize this very common condition in new mothers. Your friends, your wives, your sisters, even yourselves. You will need these tools to identify postpartum depression because she or you are going to want to hide the scary symptoms that come with it. PPD is a perinatal mood disorder caused by physical changes in women. Hormones drastically shift and drop after we have babies, causing emotional repercussions that are made even more severe when we are sleep deprived. According to Postpartum Support International, PPD is the most common complication of childbirth, impacting approximately 15% of women. Yet it's incredibly rare to hear anyone talk about it. Postpartum psychosis is even more taboo. It's that lovely little illness that causes those delusions and paranoia that I suffer from. And it only occurs in every one of every 1,000 births. In the most tragic and rare cases, those dark visions become actions, and the women can hurt or kill themselves or their children. I started feeling like something was off just a few days after giving birth. First, it became incredibly anxious and paranoid, unable to think straight. I canceled all of my plans with family and friends because making decisions about where to go and what to do just felt too heavy. I was also terrified of germs and convinced that my son was sick. I checked his temperature every hour for a fever, but he was normal. By week 2, I was completely exhausted, but I barely ever slept. When I would lay down to rest, my brain would turn on full blast, becoming a revolving wheel of negative thoughts and fear. It was right around this time when I started Googling things like postpartum depression and PPD and baby blues. It was easy to see that I had every symptom, but it was much harder to admit that fact out loud. One day I was sitting on the couch nursing our newborn when I suddenly felt warm and nauseated, like I was going to pass out. I called my OBGYN office and asked specifically about postpartum depression, but the nurse told me my symptoms sounded like dehydration. At an urgent care clinic later that morning, an EKG on my heart showed some irregularities in its beat, so the doctor sent us rushing to the ER next door. There, the technician hooked me up to an IV, ordered an MRI, and gave me a CT scan. But before any of these tests took place, a distracted cardiac specialist came into my room and barely glanced at me or my newborn baby before misdiagnosing me with a rare and deadly heart disease called Brugada syndrome. I spent that night in a dark hospital room, holding my 11-day-old baby, trying to come to terms with the fact that I was going to die and leave behind my 3 young children. The next morning, I was relieved to learn that all those tests on my heart and my brain, they came back with normal results. So physically, I was healthy, but I still felt panicky and anxious. I asked the nurses and doctors if maybe these were panic attacks caused by postpartum depression. I had just given birth after all. But the on-call nurse practitioner who breezed in and then out of my room with my discharge papers told me I was simply dehydrated and needed more rest. So over the next few days, I focused on eating, drinking water, resting, giving myself the space and the time to recover from childbirth. I even visited my OBGYN office in person this time, asking more questions about PPD. But this time, I was told not to jump to any conclusions or to rush into taking medication, and instead to first try talking it out with a therapist. But unfortunately, my situation got much worse before I started any treatment. 2.5 weeks postpartum, I had a severe panic attack that lasted over 24 hours. I actually began hallucinating. We were at the park and I actually envisioned my children being attacked violently by the Canadian geese that were grazing in the grass nearby. Then on our walk home, I had more visions, this time of my kids being run over by cars and killed. I was so shaken with anxiety that I was convinced I was having an actual heart attack. I told my husband, something isn't right. Perhaps I'm bleeding internally, or maybe I actually do have Brugada syndrome. On our way back to the ER, I nearly jumped out of our moving car when I had another hallucination, this time of our infant's car seat detaching and slamming against the side of the door. When we got there, the check-in clerk recognized me from the week prior, and she smiled at me sympathetically as she took my vitals. My heart beat normally this time, but I wasn't leaving without a diagnosis. The ER doctor came in, a different one than the week prior, and this time he spent just 5 extra minutes to actually listen to me talk about how I'd been feeling. He showed me compassion when he sat down on my hospital bed, squeezed my big toe gently, and told me I had postpartum depression. He said PPD is common, that it looks different in every woman, and that I would fully recover. He then prescribed 2 medications and told me to be patient because antidepressants can take up to 3 weeks to begin working. Now, up until this moment, I'd never suffered from serious ongoing depression before, and I'd never taken medication for anxiety. I was a healthy, mostly put together, high-functioning human. I felt like I had reached a new low. Then over the next 2 months, I suffered deeply, feeling short-tempered and agitated one moment and then uncontrollably sad the next. I cried so hard for so long some days. I thought I would dry up completely. PPD made me hate myself, inside and out. I referred to myself daily as lovely little pet names like vegetable and psychopath and crazy person. I thought I was lazy and disgusting and a horrible mother. I blamed myself for PPD, thinking I must have done something to deserve this. And on that hot night in July, when my fan hissed those scary demands above me about singeing my children's clothing, my thoughts also carried me one step further. I actually envisioned walking to the drawer in the kitchen where we keep our matches. I didn't think I would actually burn or kill my kids. Just to be sure, I made my husband hold my hand that night while we both lay awake in the dark, just to keep me accountable. My youngest son is 1.5 now. We all survived this. Yay. But I am most definitely still a work in progress, guys. I still take a daily medication to cope with my anxiety. And like any human, I still have plenty of days when I feel worthless. But at my lowest point, I thought I would never function or work or be normal again. And yet here I am. Moms, PPD is not your fault. But your symptoms are real. Get treatment now. You will recover from this very common condition in new mothers. And when you do, I hope you will share your story with every mom you know. We all need to start talking about postpartum depression. Thank you very much.
Okay, I'm going to stop sharing for a minute just to kind of solicit some feedback. What were your thoughts? Just reflecting on this. What did you guys think? Anything come up?
I can recall, it brought up a couple things that I remember because I've been doing this probably 40 years now, but psych and just remembering even family members or seeing in clinic, the downplaying of patients' symptoms, telling them, oh, you really don't want to do that, or, just downplaying it to them. And then they start agreeing and being embarrassed and then just taking it kind of all back and then wind up leaving. Or even things like, back in the day, like, oh, you just need a new nightgown, or you just need a negligee, or you just need to, be a little more sexy for your husband, or things like that. I remember them used to say to women.
Oh, wow.
Yeah, things like that.
That's definitely not helping postpartum depression.
I remember. And then I think even lately, the women's fear of having protective service involved, maybe losing their children if they bring these things up, that maybe something would happen, that their children would be taken away from them.
Yeah. Yeah, thank you for sharing that. Thank you, Dorit. Anybody else?
I think I've ran into this part of psychosis most with young mothers, and to me is very, very frightening. And unfortunately, there's been instances where I have sent them to the hospital and the ER has just sent them back home and done nothing. Especially this one mother, I remember she wanted to get a knife and stab her baby, and she said that she loved him so much, but if there was a knife, she would probably stab him. So it's very frightening, and I do think that it needs to be taken more serious and questioned more closely.
Yeah, you broke up a little there at the end. I couldn't understand what you're saying at the end, Chandra. But yeah, I think that can be really frustrating, right? Because many of the times, the postpartum psychosis, it's so, by the time they're coming for help, like we saw in the video, right? Like they're really having some problems. There's some serious things going on. And sometimes when we're not screening and we're not identifying it appropriately, it can be really problematic. Yeah, absolutely.
The one thing that I always like to kind of bring people's awareness to, I was doing a forensic evaluation a number of years ago, and the woman had basically gone naked, ran around the house. I think she probably had attacked her husband, and everybody just said it's bipolar disorder. This is why she did it. And in talking to her, she had just begun weaning her 1-year-old off of breast milk. And nobody would listen to me when I said, wait a second, guys, this is postpartum. This is related to postpartum. And they're like, no, it's not. The kid's a 1.5 years old. And I was like, so I try to always encourage people to think about this postpartum depression as any time there's that huge change in the hormones. And so that it can even be after you stopping of breastfeeding, because it was a hugely impactful experience for her. And it was something I didn't really think about until I had gone through it myself. And actually probably only thought about it because I was weaning at the same time I was seeing this person, and it hit a little close to home, but
yeah, I think that's a really good point, Colleen. I think that's definitely something that we don't take into consideration, is when they're weaning off of breast milk, that's a physical and an emotional change, right? So it's a hormonal change that has an influence, and then the emotional change too, right? A lot of moms have a difficult time with that, separating from the baby. And so I think that's a really good point. Yeah. Paris, did you have something?
Okay, sorry. So I have actually a client that I see who she's had some psychosis issues before, so I wasn't really surprised. But some of her description of what she was going through was she was kind of in a state where she was hearing voices and entities telling her that she needed to wake up certain people of the house or else they would die. Now, does it always have to be like targeted at the child from their own viewpoint, or threats as far as the psychosis goes? Was that harm?
No, any auditory hallucination.
Okay, all right.
Yeah. Good question though.
That's really fascinating because my mind went to SIDS, right? Like if I don't wake someone up, someone's going to die, probably in some way connected back to this fear of like the baby just suddenly dying at night.
Yeah. Yeah. And like we saw in the video, this mother talking about constantly feeling like her kids are sick, and I mean, that was more of her anxiety, but the psychosis can start in that way too. Yeah. Good questions. Anybody else?
Just one more thing I wanted to mention. I've actually seen it the opposite as well, is psychosis, especially in my arena, seeing it say like on a weekend or a late night towards the weekend. We used to see coming in saying psychosis with some type of history at some point in their life, but not ruling out the organic as soon as possible, which can be fatal. So yeah, considering that as well.
Yeah. Thank you. Thank you, Dorit. Am I saying that right, Dorit? Okay. All right. Just making sure. Okay. So I'm going to go back to sharing. And we're going to move maybe. So the screenings for that are recommended are the PHQ-9 for depression, which many of you have talked about and are very familiar with, right? So it takes less than 5 minutes, 9 items. This will help you identify depression. And so this is more of a recommendation perinatally. So during pregnancy, this is what's recommended by the NIH to utilize with maternal depression. And then the Edinburgh, or the Edinburgh postpartum depression scale is the one that we use for postpartum. And so we utilize that. All of the OB offices that I work with utilize that. The MIC utilizes that, the NICU. So you want to utilize this and think about and ask them within the past 7 days. So and I continue to utilize it to help them identify the score going down. So anything above 10 is concerning. And then the last question about suicide kind of opens up for that discussion. And so it's really helpful. It's helpful to identify. I'm going to talk about 2 cases, and the one case that I'm going to talk about, her score was like a 22, and then the other one was a 19. And it slowly went down. So it's a good way to monitor where they're at along with therapy. So and to screen and to identify and to get them into treatment is really important. So this is a great way to identify. And I know even some of the I work with a couple midwives, and they'll even say, hey, like this is where they know where the cutoff is for the Edinburgh, but they're not really sure sometimes. So they'll reach out, and I'm totally fine with that, because I'd rather people get into treatment if they need it than to miss somebody. And so it's really important.
Amanda, if you'll let me just make a quick comment. I just really want to echo how much I like the Edinburgh, really to separate out those physical constitutional symptoms from what's true illness. But one of the other things that has kind of come out with this, and since I know we have a lot of pediatric people on the talk, I really wanted to sort of empower them to think about that as well, because one of the things that happened in sort of the OB world about screenings for postpartum illness is lots of times they don't keep their OB follow-ups, or they don't keep appointments for themselves. They tend to keep appointments for the child or with the pediatric folks or the therapy part. And so there's been a bit of a shift in really trying to get more pediatric providers to think about giving these questionnaires to the parents to really assess them, because it really does impact their kids so much. And so that's a really, really good one to have. We sometimes, as on the pediatric end, don't always think about trying to help the parent. We do, but sometimes through the child or not directly with the parent. And there's really been some encouragement for pediatric providers to give that more regularly in the course of care for
Yeah.
kids.
I have filled it out so many times for my kids' pediatrician, but where they're dropping the ball is there's no conversation. You fill out the measure and then they never talk about it, good or bad. Like,
Oh,
that little education piece needs to be there.
yeah, I think that's really good feedback, Colleen, because I think that like the conversations I have with OB at times, they don't know what to do with it after that, right? Like, I don't know what to do with it after this. And so giving some direction, I'm happy if any of you, the Edinburgh, I mean, it's free domain, so you can go on and you can print it off. It has like, most have like a scoring kind of guideline. So you can identify, again, 10 or above is some concern. And then the suicidal ideations, absolutely you want to address that. And I think sometimes that scares people. Like if they say yes to suicidal ideations, what do you do at that point? And so
I thought about checking yes. I thought about checking yes at the pediatrician's office
just to see what they say.
Just to see if they would like
Yeah.
have a conversation with me about it. I don't think they would have. I think they would have just ignored it.
It sounds like a project, Colleen. We should totally do that. Now, I will say, like, if any of you are not using the Edinburgh and you have moms that you're worried, please feel free to reach out to me. If you're thinking about giving them the screening, absolutely. There's a lot of literature supports to give the screening and allow the moms to fill it out themselves. Sometimes what they've found is that more moms are more likely to be open if they're filling it out themselves and able to just hand it back versus having a conversation and telling you. There's some literature that oppose that though and says that the conversation opens up for discussion. And so I like both ways. I think I'm more of a conversation person, so I typically have that conversation, but many of the times I will give it to moms to just complete. So if you are interested in doing that, I mean, please feel free to reach out to me, or if you do it and you're like, I don't know what to do at this point, or I'm not sure how to, please reach out to me. I'm more than happy to help provide any type of consultation or guidance on that. So if that's something that you're interested in. So treatment, the NIH recommends CBT and IPT for postpartum depression. And so those are the most common treatments within postpartum depression, because again, you're seeing some of that depression and anxiety mixed, and both will hit that. The IPT will hit some of that perinatal depression too. And so hitting some of those moods and some perinatal mood disorders that might be springing up too. So from the National Center for Infant and Early Childhood Health Policy, they talk about medications. They talk about some antidepressants and anti-anxieties. There's a lot that pregnant women cannot take. This is not my specialty area. So if you have questions on this, maybe Dr. Swire can help you out a little bit more with that. But as far as other type of treatment, they do look at hormonal therapy to help and assist. They also talk a lot about alternative therapy. And I feel like many of us already do this if you're working with pregnant women or early moms, talking about taking time for themselves, relaxation, coaching, music, massage therapy. I talk with moms all the time. I am a huge component of self-care, right? And so we talk about ways to self-care, meditate, help yourself, and that really helps moms when they're able to do that. Moms, especially during the pandemic, I had one, I think I shared this story with you guys, but in my my substance use disorder group, I had one mom that was like, that's it, I'm going to start dressing up and putting on earrings every day, even if I'm not going anywhere. And it improved her mood significantly, right? She had a 3-month-old baby, and she was like, I feel like I don't do anything or go anywhere. And so she did that and improved her mood. Like she even the next group, she had earrings on, and I was like, those are fabulous earrings. She's like, I know, I get all dressed up every day now. So, and that's sometimes what people need. ECT, so I had a couple moms who've had really serious depression and have had to go towards ECT. Now, you know, the literature supports that most of the times if they have postpartum depression after more than one child, that it's most likely that it's a bipolar diagnosis. And so the moms that I have worked with have had bipolar diagnosis as well. So that could be why they led to that with you, Colleen. So just a couple cases to get you guys thinking about it or sharing your cases. I'm going to stop sharing my screen because I know these cases. You know, one of my cases, in going back to your comment of moms being scared of, you know, CPS being called on them and you know, being reported. I think that is a fear, and I'm always really upfront with my moms, and I talk about that because sometimes the things they share are very scary. And one of the techniques that is really beneficial with postpartum depression is journaling. And so a lot of studies have identified that even in the hospitals, moms start journaling, it can be super beneficial in journaling their true thoughts. And sometimes their thoughts are pretty dark. And so really processing through that. One of my moms did that, and she was able to kind of eventually share some of her true thoughts. But I always make moms aware that that's not my first call. Like CPS is there if there's a safety concern, and we'll set up as much safety as possible. Now, as you guys heard in that video, and again, like the most successful optimal treatment is supportive environment. And many of the times my moms who do not have a supportive environment, you know, they have a very difficult time. And my most successful moms have a very supportive environment, right? A supportive significant other. And like you heard this mother in this video talk about how she had to wake her husband up to hold her hands all night, right? And that's support. That's what you need. I did have one mom once that was 19 years old and very young. She struggled with postpartum depression. She didn't show any signs of depression perinatally. I saw her for a long period of time, tons of trauma, huge trauma history, right? And we talked about intergenerational trauma and some of that peaking for her. And then when she delivered, she had hit postpartum depression pretty significantly. She didn't have real reliable supports. Her significant other had a substance use disorder, and her father had a substance use disorder, and her mother was no longer talking to her. And so she struggled with supports. And so we identified through screening, we used the Edinburgh, we identified through screening that she had postpartum depression. She was placed on meds, but like in the video, and she talked about it sometimes takes 3 weeks. A week into that, she had told me how she plans to kill her baby and how she's going to do it. And she definitely had means to do it. She had a very specific story of how she would do it and when she wanted to do it. And we talked about that, and she's like, but I'm not. So then she's like, but I'm not. And so when I assessed to help assure like what changed her thoughts, and she was not able to secure that. And so I did have to contact for her. The only reason I did have to contact for her is because I could not find any supports to help her at that point. I tried to get her to call somebody at that point so that she would not be left alone with the baby. And we talked about that. Let's develop a safety plan. How can we keep you safe? How can we keep the baby safe? Let's develop a safety plan. She had no supports to call. And the one support she did have to call did not answer. And so I did have to contact CPS for that case. And I will say, you know, I did lose that case. She stopped coming to me after that. And it's really unfortunate, but at the end of the day, I still had to keep that baby safe too. And so, you know, I think that can be disheartening. But again, I make all of my mothers aware, like I will do everything I can in my power to safety contract with you and make sure that you're safe and the baby's safe. And if I cannot, then I do have to contact.
I mean, a question for you on that. What makes you go the report to CPS route? And it might not be an either or hospitalize her?
She didn't have any self-harm. So she didn't have any self-harm, and it wasn't aggressive. So for CPS, and she wasn't, and And in that specific situation, thank you for asking that because it's a very good question. But in that specific situation, she wasn't going directly home, right? I knew she had another appointment after that, and I know she followed up with it. And so absolutely. And with the CPS route too, what they'll do is they'll contact the police, who will also do a mental hygiene health check on her. Yeah, so that's a great question, Colleen. And if I had to hospitalize her, it would be her going to the ED, right? Or me calling mental hygiene myself. Yeah. Good question. Any other
Now, if
questions?
you hospitalized her, would you have to call CPS because there was no one to watch the baby?
I don't know if I have to, but I would still call CPS. Although I am guessing that in that situation, I probably would have had to have gotten the police involved. She did get pretty bad. So I was thinking I had to get the police involved anyways, but probably would have had to get the police involved, who would have contacted CPS. So another case that I wanted to talk to you guys about, I had and this was a more successful case. It was a 22-year-old who came to me during her pregnancy. So the last one did too, but this one came to me during her pregnancy. She was concerned with her son, who was 2 at the time, who was becoming a little bit aggressive with her, frustrated at the pregnancy, becoming aggressive with her. And her concern was that it was triggering some of her past trauma. She has a history of depression. And so she kind of wanted to get a jump start on that. She started processing her trauma. After her delivery, she had some significant postpartum depression. I actually, with her, I hospitalized her. So this is like one of those successful cases, right? She needed hospitalized. She knew she needed hospitalized. She called me and came in preparation to be hospitalized with her husband, who was very supportive of her, helped her with her younger son and the new baby, and through this process. And so she was able to be hospitalized. She then went to our partial hospitalization after that, and she's doing well now. But she definitely needed some early on treatment. So that goes to show the difference in support, right? And I think that support is so significant, and so much of the literature supports that, supports that with the support, right? That the support is really a significant factor in these cases. And so I think that that's really important to remember. Any other questions, comments, concerns?
I did want to mention, Amanda,
Yeah.
I am assisting with transcranial magnet stimulation now. So the alternative to ECT that I heard you talk about. So that is available. And the Medicaid patients have been, pretty successful in getting approved for those procedures.
Oh, good. Yeah. Do you want to talk about that a little bit?
You probably can't see my chair behind me. It's all blurred out, but the process, of course, to evaluate the patient, they do have to be referred. And then psychiatry does their evaluation, and there are specific psychiatrists through our center here that evaluate them to see if they meet the criteria. And then our neurologist here is Dr. Najib, who will go over that and see neurologically and medically if they would be clear to complete the stimulation. We do treat depression, anxiety, some types of pain. There are a few things that insurance does approve the stimulation for, and this isn't a deep stimulation that I'm talking about, like the addiction type of stimulation, but for the depression, it's typically every day for the first 5 days a week for the first 4 to 6 weeks, and then 3 times a week, probably for at least 6 weeks to a couple months, and then 2 times a week, and then for probably a couple months there or longer, depending on how they're doing, how their mood is doing. So, but there's no IV, no anesthesia, no NPO. They can drive themselves. Doesn't create a seizure, nothing like that. So, if you can see this behind me, it's kind of blurred a little bit for just the privacy thing, but you can see the chair and there's a magnet there.
Thank you. Thank you for sharing that, Dora. All right. That's all I have.
Thank you so much, Amanda, as always. Really great didactic. And I always love how you include videos. It really is, for me, I'm a visual person. So seeing that really kind of puts it to your didactic too. And it's just so impactful. So thank you so much. Did anyone have any final thoughts, comments, anything that they wanted to bring up with the group? Alrighty, well, if there are any questions after the fact, always feel free to shoot me an email and I'll try to have it addressed as soon as possible. My only announcement is that our next session will be on November 17th from 12:30 to 1:30, and Jenna Loans is going to present on attunement and co-regulation. So keep an eye out for that reminder, and we'll see you all next time. Thanks, everyone.